I'm curious to know who the losers are from the current, what the industry losers are from when you go to the current system into Obamacare. My guess is they're the people who are fighting Obamacare behind the curve.
Okay, so let me just, everyone probably heard it, but the industry losers from the introduction of Obamacare.
So it's a complicated picture. In general, I would say, I mean, if you just want to do it on an economic analysis, then it would be higher income individuals who will be paying the new Medicare taxes, who already have health insurance anyway and don't really need it. I would say those are the significant losers. Within the healthcare industry itself, of course, there are a variety of different stakeholders. There's hospitals, physicians, home health, the insurance companies, businesses. Of course, there's big business and small business. There's insured business and self-insured business. And so for all of those, there were new costs imposed. And some of those costs are balanced by benefits, and some of them are not. In general, though, there was the ethos of shared responsibility that everybody has to be a part of this. One of the industries that has been pushing the hardest and has said it's been the most unfair is the medical device manufacturing industry, who had a new tax imposed on them. And they are saying, well, it's not fair. They were big proponents of health reform. They were active in promoting it. But then when it came to the notion of, so everybody has to help pay to make this happen, they said, everybody but us. We don't want to be a part of this. Keep us out. And so they've been engaged in a sustained attack. The tax on them actually took effect in January. And we haven't seen the adverse outcome that was predicted as a result of it. They are figuring out how to absorb it. But so it's not a simple question. And it's not a question for which there's a factual answer because so much of this is subject to your own interpretation and sense. But I would say, if there's one group of people who lose and don't get much in return, it is higher income individuals and families who are paying the new Medicare taxes. Everybody else, it's a little bit of a murkier proposition.
Other questions? Right there, the woman in the back there, Brian, in the black sweater. Oh, great. Thank you. You have two handheld microphones.
Hi. I was wondering if you have any statistics, like from employers, to see if their sick time and attendance has improved with the new Medicare. I mean, the Massachusetts.
The answer to that is no. We don't. I mean, I'm trying to think whether I've even seen small studies. I haven't seen it. We're not a good, in that sense, we're not the best laboratory because, as I mentioned earlier, it was only 6%. We only had moved from 6 to 2%, and we had an employer base who largely offered health insurance. So you're asking a very good question. We are interested in looking at that question about cost savings associated with absenteeism and other indicators of maybe more productivity at work. I just don't think a study has looked at that yet.
There's one indicator that I could mention, and that is measures of states in terms of how receptive they are to entrepreneurs. And for most of the first decade of the new century, the 2000s, Massachusetts actually, I think surprisingly to some, was voted the most receptive state to entrepreneurs starting new business. And then the question is, so what happened in 2007 and beyond? And actually, the people who do the ranking said that after 2007, the state's position as number one actually accelerated and became stronger. And if you think about it, there's actually a logic behind it, because if you're starting a new business and you need to have some skilled or higher income workers, and you don't have the resources necessary to provide health insurance when you're starting up, there's a place that you can point people to go in Massachusetts where they're guaranteed the ability to be able to buy health insurance. And so it actually makes the challenge of starting a new business easier. This is going to be witnessed across the country when the ACA unfolds next year, that this actually frees people up in terms of not being stuck in their jobs and gives people the security to go out and take more risks in terms of starting up a new business, because the health insurance piece is so more certain and secure because there's guaranteed opportunity for you to buy at an affordable price.
Okay, right there.
I'm curious if Obamacare will have much of an effect on what's been done in Massachusetts, if it will have, for better or worse, if it will have any negative impacts on reform here, or if it will purely just, complement it. And what's happening in chain restaurants? Calorie charts?
Calorie menus.
Can you talk a little about that?
Yeah, sure.
And sorry to load it on. I think, Mr. McDonough, I think you said that the ACA, it hasn't even gone as far as you would like to see it have gone. Can you talk a little bit about that as well?
Let me just, so the first question,
There's 3 questions.
yeah, how about you just address the first one, which is, does Obamacare, what implications does it have, if any, for the state of Massachusetts, which has already had health reform since 2000?
So compared to the other 49 states, it's no heavy lift. But if you actually then have to actually, at the level of the connector and the state, actually have to match the two up, it's a significant number of changes. And it's not an easy lift for the people who are engaged in conforming the two right now. There's one thing that the state did that I was very pleased with. So, I mentioned that there are, in Title I, you all know what Title I is, right? Title I, there are subsidies to make the purchase of health insurance affordable. There's subsidies in Massachusetts reform law, and there's subsidies in the ACA. When you get beneath the surface and you look at it, the subsidies in Massachusetts are actually far more affordable than the subsidies in the ACA. The ACA subsidy structure, I would say, is not affordable enough for my own sense of what's necessary. So when the Governor Patrick, and the legislature were doing the legislation to conform Massachusetts to the ACA, they actually used some of the savings that the state will get from going into the ACA and made sure that the affordability in Massachusetts will be maintained at the prior level. And so that is a significant and substantive adaptation that I think will well serve people in Massachusetts, and unfortunately, people in the other 49 states will not have the same degree of continuing affordability that we've experienced in Massachusetts.
I can take the second question. So the second question you asked was about calorie labeling on fast food restaurants. So this is an interesting, this is kind of an interesting scenario. Calorie labeling in fast food restaurants was spreading, I would say, pretty quickly through the country. States after states were passing regulations or laws to mandate it. New York City had started doing it several years earlier. And in Massachusetts, we actually passed a regulation that was going to mandate it go into effect in 2008. The inclusion in the Affordable Care Act was kind of a double-edged sword, because what it did was it said no state action or city action can be taken any longer on this issue. It's been resolved at the federal level, and it sounded good because it said we're going to have national standards that apply to fast food chains everywhere. The problem is we're 4 years into this now, and the regulations have never been passed. So, and there's been, as you would guess, strong industry opposition to going ahead. So the tobacco industry, I would say, has in different times thought that the best way to kill a bill is to empower someone else with the right to regulate it and then, create all kinds of obstacles. I think that there's promise now that this is actually may get to the finish line next year. But 4 years of debating what these rules should be and having them end up being exactly what we knew they should be on day one is, a funny course of progress. The good news is it'll apply to Mississippi and Alabama, as well as Massachusetts and New York, and had it not been in the Affordable Care Act, it wouldn't apply to those other states where obesity levels are really high.
This small section in Title V is just a hoot. You could do a whole book just on this little section. So you asked what would I strengthen? So let me tell you one of the places where I most disagree with the Obama administration in their implementation of the law. When they came out with the draft rules, they chose to exempt the calorie labeling requirements from movie theaters. You think of those big tubs of popcorn and the big super-sized drinks and so forth. But it is moving forward. There was a great one chain, McDonald's, actually jumped the gun and started implementing calorie labeling a year ago. And it was a fascinating little anecdote, although unevenly. Sarah Cliff from the Washington Post, who's a great health writer down there, decided when this happened last fall, she wanted to actually see what was going on. So she walked into one of the local McDonald's in Washington, D.C. to see what was going on there. There were, all the calories listed and so on. And she saw this guy standing there staring up at her. And so she went up to him. She said, "What are you looking at?" He says, "Well, look, up there, they're showing all the calories of everything on the menu." And she thought, "Yeah, what do you think of it?" This is fantastic. This is great that a corporation is coming forward and giving this information to us. And the best thing is, it's not like some mandate from Obamacare. So she got to see, she said, "I hate to tell you, but it's a mandate from Obamacare." So he steps back and he says, "Whoa, well, if that's the case, then, I really have to rethink what I feel about this. We have to draw the line somewhere."
It's funny though, because I come from New York, which has had this for a while.
Yeah.
You just explained to me why. I was very shocked Massachusetts didn't have this.
We passed it.
Yeah.
I passed it.
It's very helpful. I mean, my whole family now goes out to dinner and just studies the menu. Let's do one right there.
First, let me say how helpful I think these presentations have been incredibly helpful, so thank you both. My question is this. I wonder if there's any research that has been done on the Mass Healthcare Connector, which I presume is going to be used as a model for other states around the country, to verify that the connector, in fact, enables people to pick the insurance package that is really most appropriate for them in their situation. I ask this question because I'll be turning 65 next month, and so I was shopping for Medicare coverage. And I found that the connector was, well, at first I started with a Shine counselor who said to me, how healthy do you plan to be over the next year? And then I went to the Mass Healthcare Connector, which was much more helpful, but it seemed to me that if one didn't have a reasonably high level of education, when we're mentally impaired, as one was getting older, we would have a lot of difficulty making use of this information. So I wonder how it really has helped people make better decisions.
I don't know if there's been a formal research study. I think that there's been good there's evidence that it's been widely used. There's feedback that people have had positive experiences with it. I think that there has been an effort to supplement the ways of working with populations who may be, say, not literate or less literate or non-English speaking in other ways other than the connector. So for example, particularly in the early years, there were grants that went to organizations like Healthcare for All, to fund the services they still have. They just don't have the same level of funding from external sources, to have helplines, so that if you call up and you just can find it very confusing, even if you go to the connector, you can call someone up and in your own language explain to them your situation, and they'll actually walk it through with you and help you to figure that out. So for some people, that's what's necessary, and luckily we've got organizations like Healthcare for All that offer that service.
John Auerbach. I was a little surprised that one of your charts showed that people's concern about out-of-pocket costs, at least in the Commonwealth, has actually been declining, because you hear from a variety of sources of all kinds of cost shifting, whether it's employers degrading the share of the premium that they pay, or whether it's some of the insurance companies that are approved by the connector being a little bit sketchy in what they cover, what they don't cover, particularly with the high deductible and the high copay policies. So do you believe your own data in terms of people self-reporting, and are there good data on actual cost shifting and increased out-of-pocket costs? And what do you think the trend is going to be now that you have this model going nationally? Because the easy way out is to get cost containment via cost shifting.
Yeah. So let me clarify. First of all, what did the question ask? The question specifically excluded the cost of premiums. So this isn't about your premiums. This is about premiums aren't covered. It covered things like copays and deductibles. So that, and it restricted it to that particular question. I think if you had asked people about premiums, they might have said, something different. They pay more on your premium. But it was looking for the ones that were, the additional costs beyond that. Self-report. I think my guess is, you can question whether or not that's reliable. My inclination would be people always think they spend more than they actually do. So I was actually surprised to see that people were just reporting it somewhat differently. I don't recall having seen a study that actually tried to scientifically assess that. I will say this though about one of the things that the connector does do well is the connector is pretty good at laying out for you what the costs and benefits are of different premiums. Because in general, the rule is, you may have seen this with the platinum, gold, silver, bronze way that they categorize premiums. They'll say, well, you can pay like a really low premium. But then if you have something and you need to go in to see a doctor, you're going to pay a really high copay or deductible. On the other hand, if you think you're going to use the system a lot, it might be better to pay a higher premium and then, not have to worry about those copays and deductibles. So I think part of this is really educating the public that there are trade-offs, and that by and large, if you're going to pay a lower premium, the insurance companies are likely to switch the cost over to the copay and deductible.
Are you concerned about a trend of greater cost shifting?
Sure. I'm concerned. I think it's worth monitoring very carefully. And it's worth thinking about how do you gather that information. Another way that I would say you gather it is that question we asked, which was, did you need care and health and money was an obstacle? Because that's a different way of asking it, but it captures some of that. That's a good question.
Okay, let's go over here. Anyone have a question? Right there, the woman in green.
Hi. First, this is a question for Professor John A. As far as Massachusetts, are there new rules being set in place in different hospitals and healthcare centers in order to push the accountable, the ACOs, like community resource specialists or more nurse practitioners in place?
Let's see. I'd say that we're increasingly shifting to more and more reimbursement that's global, and there are more and more models like that. As those models become more prevalent, I think there are indications that the primary care sites and the hospitals are looking creatively at how they should practice differently. But there's a good deal of unevenness in terms of what it actually looks like. There are places I would hold up, like the kind of place I would say, this might give you a sense of what an accountable care organization is. I would say is a provider like Atrius. Atrius does a lot of outpatient care. It includes Harvard Vanguard. So they're doing things like saying, we don't want you to go to the emergency room, so we're going to make sure there's 24-hour nursing coverage by telephone, so that you can actually talk to a clinician if you're feeling bad in the middle of the night, and maybe get discouraged from going in if it doesn't really not necessary. So there's some of that kind of experimentation, but there aren't strict rules about what it needs to look like. So different providers are trying different things. I hear not infrequently from community health centers where they're a little uncertain about, should they be doing it this way or should they be doing it that way? I think we're seeing a lot of experimentation, and we probably will for, I think, a few years.
Okay, we're entering the lightning round. Let's do 2 more questions, but let's make them, fairly succinct, and then you can respond.
Yes, give us yes or no questions.
Or maybe. How about right there?
Would Herbert Spencer, the major enunciator of social Darwinism, be upset with these measures, and should we be at all concerned about understanding his concerns were he alive? Because that's the question.
I defer to John.
Remember when the lightning round?
Maybe, I think it's the answer.
Herbert Spencer was a friend of mine. He wrote a lot of different things. Social Darwinism, I compared to what, I guess? I'm sorry, I have to find.
Okay, let's, one more right there.
I'm going to cheat. I'm just going to ask. I heard the answer about whether there was compression of new business. But is there evidence of compression beyond the 11 employees? In other words, people stalling to grow their business because of the health insurance employer scenario. And of the 120,000 that equals the 2%, is there any understanding of how much of that is homelessness?
Let me answer the second question first. There's a disproportionate number of people who are low income that are part of that 2%, and there's a disproportionate number of people whose lives are in disruption. They may, because to enroll in insurance, you have to actually have a certain degree of stability in your life. So I would guess that there's a higher percentage of homeless people among those 2%. That said, there really are some good efforts now when people show up in the emergency room, or with efforts like healthcare for the homeless in the greater Boston area, to work very sensitively with the population and figure out how to maximize the coverage that's available. But sure, I think we would find that it would be that we would find a disproportionate number. On the compression, I don't know the answer to the compression question. Do you know?
I would just note though that there's something that's going to be fundamentally different. So we still have 120,000 uninsured in Massachusetts. Even when the ACA is fully implemented now because of the Supreme Court on Medicaid, we will still have, the estimate is over 30 million uninsured in the United States. But now the important thing to understand is that the nature of the uninsured population and the nature of uninsurance is going to fundamentally change. Because the largest block of the uninsured in Massachusetts and nationally are people who are eligible for Medicaid and unenrolled. And what's different is when the ACA is fully implemented is that if you are uninsured, and you get sick and you need medical care, you show up at a hospital or a health center and you can get signed up on the spot. So it's different than the situation now. The one group for whom there is not the instant access to some kind of coverage is our undocumented immigrants. That is the group for which there's status quo and no change. But for just about everybody else, the nature of uninsurance changes because you may, it's not really an individual mandate. That's a misnomer. What it is it is a tax penalty on people who can afford to buy coverage and choose not to purchase it. So those 120,000 people in Massachusetts who don't have health insurance, they're not breaking any law. They're paying a penalty. They're in conformity with the law.
Or many of them can make a case that they're too poor to buy insurance, and then they don't have to pay the penalties.
So the nature of uninsurance is different, and there is no Massachusetts unemployment rate has been consistently below the national average for the past 6 years or so. So there's really no evidence that we can really point to that says that there's some significant job compression going on in Massachusetts, which doesn't tell you it won't happen elsewhere around the country, but there's no real evidence in Massachusetts of that.
Okay, please join me in giving another big Thanks again, both of you, for a great discussion, your presentations. Just before you leave, next week, the mayor will be here, and this session come early if you want a seat. It'll probably be a very good crowd, and this will be, as it states, reflections on a career. We'll talk about some of the mayor's achievements in healthcare in the city of Boston during his tenure as mayor. And